Hello everyone. So we will be talking about this interesting case today. So what if you see 45-year-old woman came in because of frequent urination and fatigue over the past 2 weeks. There is hyperglycemia as well. So you check glucose is 250. This is pretty high. What would you do? Best next step in this patient? BMI is good. There's just like diabetes symptoms, You're suspecting diabetes in an old lady. So what would confirm this type 1 or type 2 diabetic? You do antibodies to glutamic acid decarboxylase. You check antibodies to glutamic acid decarboxylase. So there are different types of diabetes. There's type 1 when there's insulin deficiency, you severe hyperglycemic symptoms in young patients, normal BMI. You can see positive islet cell antibodies or glutamic acid decarboxylase antibodies and absent C-peptide. You need immediate insulin therapy. And there is one latent like LADA, which is latent autoimmune diabetes of adulthood, which is not rapid insulin deficiency, it's slow insulin deficiency, causes mild hyperglycemic symptoms, early adult, like 30 to 50, causes low normal BMI, and then you have positive islet cell antibodies and latent autoimmune diabetes of adulthood. It causes positive gamma glutamic acid decarboxylase antibodies, and then low C-peptide. How do you manage it? You give oral agent initially, and then insulin required more than 6 months after diagnosis. Okay. And you have type 2 diabetes, which is insulin resistance. There is insulin, but the resistance in the beginning, and then later you can have deficiency. It happened in adult and high BMI. You have negative antibodies, high C-peptide, and then you need oral agent, and you may need insulin later stages. Okay. So this is like a summary of diabetes management, okay? Okay, now we get another case. You see 35-year-old man with atherosclerotic vascular disease risk is 1%. And they tell you what to do, best next step, no medications at this time, okay? Nothing to do at this time for this patient. Even if triglyceride is high, so you gotta be careful. Even if they tell you like the triglyceride like 350 or something, you still nothing to do. Okay, you don't need atorvastatin. Atorvastatin only if there's high risk for therapy. So this can be very tricky. Okay, other people that you need high statin dose, like people aged less than 75 or age more than 40 with diabetes, with high atherosclerotic vascular disease, and LDL more than 190. Now, patient have 71 having neuropathy, like pain in the in the feet, pain in feet, and A1C is 7.5. What's best next step? You do a pregabalin. Okay. So what are the treatment options for diabetic peripheral neuropathy? Antidepressant, amitriptyline, duloxetine, anticonvulsant like pregabalin, valproic acid. You need topical capsaicin acid and a cream. You need alpha lipoic acid, transcutaneous electrical nerve stimulation, and lidocaine patch. So you need all of those. Are very important. Okay. So now let's see, 40-year-old woman. Come in because excessive sweating and fine tremors. Okay, so you do TSH is less than 0.01 and you have high T3, T4, and there is like a nodule. There's a like 1.7 centimeter nodule. What's best next step? This one you do radioactive iodine uptake scan. Okay. So you need radioactive iodine uptake scan because this will tell us like when you have hyperthyroidism, like T3, T4 high, TSH is low, so the way to evaluate that, it could be multiple ways. It could be either secondary hyperparathyroidism or primary hyperparathyroidism. Secondary, usually high PTSH, high T4, okay? Results, you just do MRI of the pituitary and you know what's up. If there is low TSH but T3, T4 is high, this is a primary issue, like the son is acting up, not the dad, not the pituitary. So you check, is there a signs of Graves' disease? If there is any signs of Graves' disease, then this is Graves' disease treated as is. If there is no signs of Graves' disease, then you do radioactive iodine uptake scan. If there is high scan, then this depends on the pattern. If there is diffuse pattern, this is Graves. There is nodular pattern, that's toxic adenoma multinodular goiter. But what if there is low radioactive iodine uptake scan? Then you measure thyroglobulin level. If it's high, this is thyroiditis or iodine exposure. If it's low, then this is exogenous thyroid. Really. Okay, now you have this patient have 44-year-old with T-score of -3, and there is vertebral fracture. That's very concerning in a 44-year-old woman. Like, this is not supposed to happen. So what would you do? What's best next step? You do overnight dexamethasone suppression test. Okay, you need overnight dexamethasone suppression test. What are the secondary causes of premenopausal osteoporosis? Hyperthyroidism, hyperparathyroidism, vitamin D or calcium deficiency, GI malabsorption, Celiac-Pro or IBD, Cushing syndrome, and if there is estrogen deficiency like premature ovarian failure, rheumatoid arthritis. There are medications can cause premenopausal osteoporosis like steroid, chronic heparin, phenytoin, chronic kidney disease or liver disease, hypercalciuria or alcoholism. But one of the causes is Cushing, so you're going to test for it. So there are a lot of things can cause premenopausal osteoporosis. Okay, now you have a 74-year-old coming with weakness, loss of appetite, muscle tenderness, diffuse, you know. Elevated creatine kinase is slightly elevated, like 400. Even if they're taking statin, you don't just blame it on the statin. Best next step, you do thyroid function test, TFT. Okay, because there are 5 different types of neuropathy. There's steroid-induced neuropathy. Usually, it causes weakness. It's just like polymyositis, dermatomyositis, and hypothyroid myopathy. These 3 causes weakness. But polymyalgia rheumatica and statin may or may not cause the weakness. Okay. The steroid doesn't cause tenderness, but polymyalgia rheumatica, polymyositis, and statin causes tenderness. Okay. And the difference is in the steroid-induced myopathy, usually lower extremity most effective, and you see atrophy. But polymyalgia rheumatica, you see stiffness and improve with steroid. Polymyositis, you see multi-system involvement like arthritis, increased malignancy risk. Statin-induced myopathy, there is the increased risk with fibrate as well. And hypothyroid myopathy, usually associated with delayed deep tendon reflexes, myoedema, hypothyroid symptoms, abnormal thyroid results. Okay. Now they ask you, what is complications of levothyroxine? Okay, the complications could cause cardiac arrhythmia. Okay. These are the complications of levothyroxine therapy. Now, if you see somebody with radioactive iodine uptake is diffuse radioactive iodine uptake, TSH is low, okay, so you give you 52-year-old woman, like hyperthyroid symptoms, you know, weight loss, fatigue, and then you see diffuse uptake on radioactive iodine scan, low TSH, high T3, T4, what do you do best next step? This is clearly hyperthyroid. There's thyroid nodule. So what do? You do radioactive iodine ablation. Okay, you just like ablate this nodule, get rid of it, symptoms get better. All right, so this case is interesting. Somebody has gastric bypass, okay, and then after gastric bypass the patient come in with anemia, leukopenia, myeloneuropathy. Okay, what's best next step? What is the best next step? We check copper, because this could be a copper deficiency, okay, and can also cause difficulty with imbalance, falls, weakness of extensor reflexes, you know, weak flexes, falls, you know, unstable on Romberg test, you know. This because copper deficiency, you need the copper therapy, okay. Okay, now a follow-up onto the previous question. Like this patient who has hyperthyroid symptoms, you did ablation, okay. What's best next step? How to follow response to the treatment? TSH is still low. What would you do? You check T3 and free T4 level. Okay, that's how you do, because TSH can stay low for a very long time, so you don't rely on it. After thyroid ablation, that's what you want to do. This is how you assess the treatment response, if somebody responded to the treatment or not. Usually there should be an improvement within 4 to 8 weeks, and up to 80% of patients develop hypothyroidism between 2 to 4 months after treatment. Okay, but the hypothyroid should be self-limited and gets better on its own. So this is what we talked about. Talked about post-thyroid ablation therapy. We talked about copper deficiency, thyroid complications, arrhythmia, thyroid function test because weakness, dexamethasone suppression test if there is Cushing, radioiodine active uptake scan to check for Graves, precapitant for neuropathy. You wanna triglyceride high, nothing to do with it if there's low risk for coronary artery disease. You can give antibody to test antibody to glutamic acid decarboxylase if there is latent onset diabetes. That summarizes our discussion of this section of endocrine. Thank you for listening.